bit and then answer, okay? All the best to both of you all.
We are live.
A very good evening, everyone, and welcome to the next edition of case presentations. This time, of course, on very important cases that many of your residents have to present in the examinations, wherein you are presented with a case of cataract with pseudoexfoliation or a cataract with an iris coloboma. So we have two young presenters, extremely good, Dr. Preeti Abraham from Padma Shri Dr. D.Y. Patil Medical College in Pune, who's going to be ably mentored by Professor and Head of Unit, Teacher of Teachers, Dr. Renu Makhdoom. And we have Dr. Deeplata, who's a Junior Resident 3 from Rajiv Gandhi Medical College in Kalwa, who's going to be mentored by Dr. Rohit Tiwari, an Associate Professor in the same medical college. Amongst the panelists, which essentially are examiners, are Dr. Ravi Krishna Kannaradi, who from Bangalore, who apart from being an avid biker and a senior consultant cataract and refractive surgeon, is a prolific surgeon, and he'll be guiding the students through these cases, along with our own Professor Neeta Shanbag, who's professor and head at with the Vedanta Medical College in Mumbai. Of course, all our sessions are moderated by Professor Archana Vare and coordinated by our scientific secretary, Dr. Sumit Lahane. So over to you, Professor Vare and Sumit, to carry the session forward. And I wish both residents all the best for their cases.
Good evening, everyone. We will start with the first case, and the first case has 30 minutes and the second case will have 30 minutes. So the first case will be presented by Dr. Preeti, and she'll present her case, and after that the panelists will be asking her questions, and at 8:30 we'll start with the second case. So I request Dr. Preeti to share her screen and present her case.
Good evening. I would like to begin by sincerely thanking Maharashtra Ophthalmological Society and my dear faculties of Dr. D.Y. Patil Medical College, Pune, for giving me this opportunity to do a case presentation on cataract with pseudoexfoliation. A 69-year-old male resident of...
Sorry to interrupt, doctor. Can you just make it in the slideshow mode, please?
Yes.
Let's stop.
So are you able to see right now?
Thank you.
Thank you, sir. A 69-year-old male resident of Pune, farmer by occupation, came with chief complaints of diminution of vision in both the right eye more than left eye since 1 year. History of presenting illness. Patient was apparently all right 1 year back, after which he developed diminution of vision in both the right eye more than left eye, which was gradual, painless, and progressing in nature. There was history of spectacle use for 6 years, but now patient is not comfortable with the same. There is no history of previous ocular surgeries. Past medical, personal, and family history were not significant. General examination and systemic examination were within normal limit. Ocular examination of the right eye showed a vision of 1/60 PR accurate, improving to 6/60 with a correction of -3.5 diopters with -3.25 cylinder at 90 degree. And the left eye showed 1/60 PR accurate, which was not improving. Both the eye had a near vision of N24 to N18 with a correction of +3 diopters. The remaining ocular examinations were within normal limit. The anterior segment examination of the right eye showed muddy conjunctiva with a transparent cornea with normal size shape with a dense arcus present, and there were no endothelial deposits noted. The peripheral anterior chamber depth was equal to half corneal thickness, grade 2 according to Van Herrick grading. The iris was normal in color and pattern with no transillumination defect seen, or no iridodonosis was noted. The pupil was central circular 3 mm reacting to light, and there were flaky dandruff-like deposits seen on the pupillary margin all around. The maximum dilatation of this eye was 4 to 5 mm. On slit lamp examination, the nuclear sclerosis was found to be grade 2 to 3 NS with a cortical from 3 to 5 o'clock. Target sign was seen with no phacodonosis noted. The intraocular pressure, according to Goldman applanation tonometry, was 20 mm mercury at 10:30 a.m. The findings in the left eye were similar to that of the right eye. On doing gonioscopy, the right eye showed all angles showed up to scleral spur, while in the left eye, on seeing the superior angle, we could see the posterior trabecular meshwork with dense pigmentation, while in the inferior angle, posterior trabecular meshwork, along with pseudo-exfoliation and pigmented Schwalbe's line was noted. This is the gonioscopic picture showing the superior angle, which shows the densely pigmented trabecular meshwork, and the inferior angle showing pseudo-exfoliation with pigmented Schwalbe's line. The fundus examination of the right eye showed media clear with optic disc large with cup disc ratio 0.6:1 with a healthy NRR. The macula showed multiple yellow lesions with distinct margin with areas of hypopigmentation seen below the level of blood vessel, which was seen around the fovea, which was suggestive of drusense. The foveal reflex was dull and the remaining fundus was within normal limit. The fundus examination of the left eye showed asteroid hylosis in the media with the optic disc which was large with the cup disc ratio of 0.7:1 with a healthy NRR. The macula showed multiple yellow lesions with distinct margins along with areas of hypopigmentation seen below the level of blood vessel all over the macula, which was suggestive of drusense. The foveal reflex was dull, and the general fundus again showed multiple yellow lesions with distinct margins seen below the level of blood vessel in inferior and superior quadrant, which was suggestive of drusense. On doing the specular microscopy, the right eye showed a cell density of 2,331 cells per millimeter square, and the left eye showed a cell density of 2,429 cells per millimeter square. And the central corneal thickness of the right eye was 525 micrometer, and the left eye was 520 micrometer. The diagnosis in this case is both eye immature senile cataract with pseudo-exfoliation with dry, age-related macular degeneration along with left eye asteroid hylosis. Thank you.
So, Dr. Preeti, that was a good presentation, but I'll just mention 2 points. First thing is you have skipped the negative history, which is very important when you are presenting in your MS exams. Second thing is you have missed the diagnosis of compound myopic astigmatism because the patient had both eyes compound myopic astigmatism. So that you should have included in the diagnosis. Okay, with that, I'll just go to the panelist and I'll request Dr. Ravi sir to ask questions to Dr. Preeti.
Hello, Dr. Preeti. So I just want to know, how do you diagnose phacodonosis?
So
What
basically,
exactly is phacodonosis, and what is the cause of phacodonosis in pseudoexfoliation?
okay, so basically, sir, phacodonosis means tremulousness of the lens, and phacodonosis is noted when there is a loss of the zonular integrity. Because of that, the zonules are not able to hold the lens properly, and there is a movement of the lens noted.
Okay, so whether it is well appreciated in undilated pupil or dilated pupil?
Sir, it is appreciated in a dilated pupil, sir. While so we'll ask the patient to look on either sides superiorly.
That is after dilatation?
Sir,
That means you are not examining this case properly. So, if at all, if the phacodonosis is there, and you had mentioned that whether it was examined after dilated dilatation or before dilatation?
So it was seen on the anterior segment examination only, slit lamp examination before dilatation.
Before dilatation.
Yes.
Then you said after dilatation.
So basically, we'll ask the patient to look on either
No,
side.
I'm not asking you how do you diagnose.
Okay.
Just asking you when it is well appreciated. Undilated people, dilated.
So,
That means diagnosis of phacodonosis in your case is wrong. In case, if at all, if you have seen phacodonosis after dilatation, then that is wrong.
okay, sir.
Okay. So if at all, if there is phacodonosis, what is your plan for doing surgery? Ma'am, if anything is there, clinical thing, please ask. So then we'll go to the surgical thing. If anyone has anything, please.
Okay. Neeta ma'am, would you like to ask us some clinical questions? Ma'am, you're mute, ma'am. Mic is mute.
He's already disturbed. Let him go on. We will ask her later on.
Okay. So that's what. So in case if there is a phacodonosis, okay, what is your plan of management? Like for example, you after your MS, you go to you can join as a consultant and you see a case of PX of phacodonosis. And how do you plan the case?
Okay, sir. So if I find phacodonosis is present, we have to think on putting a capsular tension ring while doing the surgery so that the capsular bag is the stability of the capsular bag and the integrity is maintained.
Okay.
Will you not try to find out how many quadrants the phacodonosis is there? Where are the zonules lost?
Yes, ma'am.
Isn't your management dependent on the number of quadrants the zonules are not there or the clock hours that you don't see the zonules?
Yes, ma'am. While looking onto the capsular bag, if we find there is if it is so while doing the aspiration, if we find the capsular bag is loosely coming out, that means there is phacodonosis which is present in that quadrant, and we will think of putting a capsular tension ring only if there it is more than 6 clock hours.
Then
Dr. Preeti, that's a
Zonules are present in 6 clock hours or absent in 6 clock hours?
Zonules will be reduced, ma'am.
These subluxated lenses and phacodonosis is a very important question. You should know the management of this. He has asked you a very right question. The whole management is dependent on the loss of zonules in how many quadrants, how many clock hours, less than 90 degrees, 90 to 120 degrees. The answers are all there in the books. Capsular tension ring is not just the answer to it. Aren't there some segments to reinforce that area? Do you know about those segments?
Ma'am, I'll go through it once again, ma'am.
Okay, so we can skip this part because she is unaware of it. Let's go to something else. Sir.
So before that, Dr. Preeti, you must also not just read about this, but read about how many clock hours determines what type of additional measure you would require, whether you want to put in a segment, whether you would want to put in a ring, capsular tension ring, or whether you would want to put a CONE ring, whether you would want to suture it. It all depends on the number of clock hours. So these are very, very important questions in the management.
Okay,
Again,
so
everybody nowadays keeps on talking about capsular tension rings, phaco, this, that. Can't you just remove the lens intra if it is not very stable and just put a suture supported or an iris claw lens? Isn't that another modality of treatment?
yes, ma'am, we can.
Why do we want to take the complicated approach? The other approaches also give you good visibility and good visual recovery. So we should keep a very open mind when we are going about all this. You have to look at the age of the patient, the density of the cataract.
Yes, ma'am.
This appeared to be a very dense cataract, isn't it? What it was, grade 3, grade 4.
Yes, ma'am. That is why in soda exfoliative case, we prefer putting a three-piece IOL, ma'am, because there are complications of decentration and subluxation of the lens post-operatively also.
But you will still go ahead with the FICO, right?
Ma'am, phaco is more preferred. Why? Because phacoemulsification can be done because in pigment dispersion syndrome, because of the
Suppose
pigment.
suppose you are the operating surgeon. What will you do?
Ma'am, if I'm able to put the capsular tension ring and go ahead with my surgery, I would do prefer doing that, and definitely I would want to put a three-piece IOL also, because later on, if at all I want to do a scleral fixated IOL, because of the complications that can occur, I will prefer that more than a single piece IOL.
Your answer is absolutely correct. How many FICOs you have done?
Ma'am, I've not yet.
I asked you if you are the operating surgeon and you went ahead and said, I'll do a FICO, I'll put an endocapsular ring. You listened to the question, child. Isn't it?
Yes, ma'am.
So I'll repeat the question. If you are the operating surgeon and you don't know how to do a FICO, then what will you do?
Ma'am, I'll go ahead with small incision cataract surgery.
Now, between this, you have a choice of small incision cataract surgery and conventional cataract surgery. What would you prefer?
Ma'am, in such cases, I ideally, ma'am, in such cases, we are supposed to do a phacoemulsification surgery so that there is washing away of the pigments that are deposited. And if I am not able to do a phacoemulsification, I will definitely try to take the patient into a better, safer.
Washing away of the pigments where in the angle?
Ma'am, it is deposited in the trabecular meshwork near the zonules in the anterior
So any
segment.
form of cataract surgery, won't they get washed away, or only phacoemulsification they'll get washed away?
Ma'am, definitely in small incision, it does get washed away. But
And in conventional, it won't get washed away.
The conventional means ECC.
You have to have an open mind to understand the concept. That's
So
very,
you
very
tell me, if you have a subluxated lens, what is the size of the lens? Can you get it out through a 6 mm small incision tunnel?
we will have to go ahead with extracapsular cataracts extraction.
Or you have to take a very large tunnel, which again compromises on the structural integrity of the eye.
Yes, sir.
Because if you're going to try to get it out of a 6 mm incision, you're going to break the nucleus, damage the endothelium, lot of things.
Yes, sir.
So keep your mind open. There are other modalities of treatment which give equally good results. For many, many years, people have done conventional surgery, intra surgeries, and delivered 6x6 vision, and patients have been seeing till they were 90s and all. So phacoemulsification is not something which is dropped from the sky. Whatever is reasonably safe in your hands, whatever can give good visual outcome to the patient is to be done.
Yes, ma'am.
Okay?
Yes, ma'am.
Yeah. So please go ahead.
So let us talk about pupil. So you said pupil is around 4 to 5 mm dilatation. So what is the reason for that? Why does the pupil doesn't dilate in these cases?
So in soda exfoliation, there is absence of the pupillary rough that is seen. And because of the deposition of these fibrillary material on the pupillary margin, there is going to be force, the contact between the lens and the pupil on dilatation.
That's why it doesn't dilate. That's a synec. So any synec will not dilate. Does this PXF patient will have a synec?
Sir, not exactly as Sinec A,
Hmm.
but there will be a limited moderate dilatation. Like in the normal cataract surgery, we will not be able to get a full dilated pupil.
Anything to do
Why?
with the tone of the iris muscles?
Ma'am, because there will be atrophy of the sphincter of the iris.
Sphincter atrophy will lead to
A decrease pupillary dilatation.
you have read entire thing about PXF, right?
Yes, sir.
Preeti, I'm just asking you a very, very theoretical question. What is true exfoliation and what is pseudo exfoliation?
Ma'am, so true exfoliation is when there is a separation of the anterior there is a separation of the anterior capsule. It is most commonly seen in glass bowlers or in occupations wherein uh, heat or high infrared radiations are happening. It is basically delamination of the anterior capsule.
Okay. Ma'am, Nita ma'am, would you like to ask her some more questions?
I would like to ask her that what was her keratometry in these patients? You had a cylinder of more than 3 diopters in both the eyes, isn't it?
Yes, ma'am.
So was it a corneal astigmatism or was it a combined corneal plus lenticular astigmatism?
Ma'am,
You did the scan of the patient, no? So you have the K values.
ma'am, so
Were they matching with your retinoscopy? You have shown your retinoscopy, isn't it?
yes, ma'am.
What are the K values? That's what ma'am is asking you. Do you remember the K values?
Even if you don't remember, was it a corneal astigmatism or there was a combined astigmatism? Because my next question is dependent on that.
Ma'am, I think it is most probably a corneal astigmatism, ma'am.
So if you have a corneal astigmatism of 3 diopters and in the left eye the patient is not improving beyond 618, was it because of the cataract or was it because of something else?
Ma'am, so it is because of the cataract, and also in the left eye there was macular degeneration noted.
Fair enough. So what was the IOL power in both the eyes? They were equal or there was some difference?
Ma'am, I actually don't.
You don't remember. Okay. Now suppose you have an astigmatism which is more than 3 diopters. Any other test you would like to do to rule out some other pathology in the eye?
I think I should rule out keratoconus
No, you just have to do a
pentac.
corneal topography. You can pick up anything that comes on it. Most probably it would be a regular with the rule astigmatism because it is, I don't know, I don't remember the axis that you showed, but probably it was with the rule or was it against the rule astigmatism?
It was, ma'am, against the rule.
Okay, so now you have a 3 diopters of against the rule astigmatism. So what will be your incision site?
So my incision site will be superiorly, so that ma'am, my incision site will be superiorly.
So if you have a superior incision, it will add on to the against the rule astigmatism or it will negate the against the rule astigmatism.
Ma'am, so against the rule is when the horizontal is steeper than the vertical. So
So vertical is flat, and if you're taking a vertical incision, it will become flatter or it will become steeper.
sorry, ma'am, I have to take a temporal incision so that my steeper horizontal axis will become flat.
Yeah, because if you take a superior incision instead of 3 diopters, you will give him 4.5 diopters
Yes, ma'am.
against the rule astigmatism, and that will cause a lot of optical distortions on the patient. So your incision site has to be decided on which is the steep meridian,
Yes, ma'am.
especially when you have this kind of a thing. Now you said you want to put a 3-piece lens, you want to put a 3-piece lens. More important than that, would it not be that you would want to put a toric IOL in the patient?
Yes, ma'am.
Because it was a corneal astigmatism, na? It was not lenticular astigmatism. That is what you told me.
Yes, ma'am.
Correct?
Yes, ma'am.
So if you want to put a toric IOL and you're doing a small incision cataract surgery, how do you manage the astigmatism control?
Sorry, ma'am.
You have a 3 diopters of astigmatism and you're taking a superior tunnel or a superior conventional surgery, a superior conventional cataract surgery incision. So how are you going to manage the astigmatism now?
So I think, ma'am, in such cases, we will have to induce an astigmatism by the surgeon.
Correct. So you have to add on the surgically induced astigmatism and you will count the IOL power accordingly.
Yes, ma'am.
So a toric IOL would be more mandatory in this patient, though you cannot be on the dot because it is a very unusual case and you cannot be very precise in this particular patient. So you have to give a guarded prognosis, but try our level best to do it.
Yes, ma'am.
And after that, how are you going to monitor the intraocular pressure? It's a pseudo exfoliation patient, isn't it?
Yes, ma'am.
What were the pressures, initial pressures?
Ma'am, pressure in this patient was 20 millimeter mercury, which was done on Goldman applanation tonometry.
When all did you repeat it? Only one single reading you did.
Yes, ma'am.
Do you think you would have liked to do something better than that?
Ma'am, I think I have to keep a follow-up of the pressures because there are chances of pseudo exfoliation induced glaucoma that can come into this patient.
Suppose I have realized that my resident has taken only one pressure and the patient is admitted on the previous evening. Would I do something to know whether the pressure can rise? Anything in the house?
Ma'am, I will repeat my pressures taking into consideration the diurnal variation.
So you will do a diurnal variation for the patient. You will repeat his pressures every 2 hours to see if there is a rise in intraocular pressure. What was the cup disc ratio in this patient?
Ma'am, in the right eye, it was 0.6 and in the left eye, it was 0.8.
So
But,
that means your 20 pressures were certainly not 20 if he was 0.8 in one of the eyes, isn't it?
ma'am,
There have been fluctuations.
but the neuroretinal rim seemed to be healthy. So I was just my plan was to just keep a close follow-up of the patient by monitoring the IOP.
With a 0.8 CD ratio, you're going to monitor the patient and observe.
Ma'am, actually the disc was large.
You said CD ratio is 0.8. If it is a normal disc, small disc, or a large disc, 0.8 CD is 0.8 CD.
Yes, ma'am.
So if you have a 0.8 CD and you get an intraocular pressure of 20, something which you have to think about, isn't it? Glaucoma management comes topmost on the list here now because the CD ratio is 0.8.
Yes, ma'am. Ma'am, but I would prefer keeping the patient in close monitoring before uh, starting the patient on drugs.
Um, Ma'am, can we move on to the next case with your permission?
Yes, please. She chose a very nice case. There were too many things in it. I don't think we will need to blame her for it. But my only advice to her would be that if you have so many things, then you have to think on so many aspects and do the management of the patient. That's all.
Thank you, ma'am.
Okay. So now with this, we'll move on to the next case that is by Dr. Deep Lata. She is a resident from Rajiv Gandhi Medical College, Thane, and her mentor is Dr. Rohit Tiwari. So I request Dr. Deep Lata to share her screen and present her case.
Good evening, everyone. Myself, Dr. Deeplata. I am a junior resident. My mentor is Dr. Rohit Tiwari, Associate Professor in Rajiv Gandhi Medical College, Kalwa, Thane. I am presenting the case of Mr. Avinash Rajak, a 20-year-old male resident of Kalwa, Thane, presented with the chief complaint of diminution of vision in left eye since 1 year. History of presenting illness, the patient had diminution of vision in left eye since 10 years. During Aadhaar card verification, the attending officer spotted abnormality in left eye. However, no medical consultation was sought that time. The patient presented to us with a severe diminution of vision in left eye since 1 year, which was gradual, painless, and progressive, affecting both near and distant vision. The old photograph of patient shows opacity and deviation in left eye. There was no history of trauma to the eye or head, no history of pain and redness, no history of ocular surgery and using glasses, and no history of ocular medication. Personal history, patient is on mixed diet with no history of smoking, alcohol, and tobacco consumption. Birth history, born as full-term normal delivery with no history of delayed developmental milestones. Family history, born out non-consanguineous marriage with no history of diminution of vision in siblings and parents. Patient is nil systemic. General physical examination, patient is average build with no congenital abnormality found and systemic examination within normal limit. Ocular examination, head posture normal, facial symmetry maintained. On ocular alignment, left eye exotropia with hypertropia noted. As shown in this small video, on alternating cover and cover test, right eye taking fixation while the left eye eccentric fixation present. On ocular examination of right eye, uncorrected visual acuity 6/6 with near vision N6, and rest of the interior and the posterior segment finding was normal. Now the left eye, uncorrected visual acuity, perception of light present, and projection of rays inaccurate in inferior quadrant. Intraocular pressure with the Goldman applanation tonometer at 10 a.m., 10 millimeter of mercury. Eyelid adnexa normal, ocular movement full in all direction, conjunctiva sclera normal, cornea normal in shape and 11 into 10.5 millimeter in size and maintain transparency. Anterior chamber normal in depth and contents. Gonioscopy, open angles was open. Iris full thickness, iris defect at 5 to 7 o'clock, suggestive of iris coloboma. Pupil, irregular, sluggish reactive with no synechiae, lens developmental cataract with anterior capsular fibrosis, absence of zonule noted from 5 to 7 o'clock with no trichodonosis noted. On fundus examination, on distal direct ophthalmoscope, flow was dull in left eye and rest of the fundus was not visualized. On the left eye B scan, the thick membrane is present and it now had suggestive of retinal detachment. My provisional diagnosis is right eye emmetropia and left eye typical iris coloboma with developmental cataract with anterior capsular fibrosis, exotropia with hypertropia and retinal detachment present. Thank you.
So, good presentation, Dr. Deeplata. So, I request Dr. Ravi sir to ask questions to Dr. Deeplata.
I think Neeta ma'am can start.
No, no, sir, you start.
So, what exactly is this coloboma? Or like, what exactly, like, you said developmental cataract, all those things.
Yes,
So, what exactly is this coloboma? Like, whether it is some congenital disorder or is it some developmental anomaly?
sir, it is a congenital anomaly due to the unable of closure of embryonic fissure during 6 to 7 week of gestation.
Okay. Then, okay. Regarding examination, I think Neeta ma'am can ask, like for clinical management, like how do you want to address this case? Like how do you want to manage this case?
First, first I will explain about the prognosis to the patient and their relative. Because the vision is very low and the suggestive retinal detachment also present with the cataract. So I would like to go for the first cataract surgery, then the retinal detachment repair.
Okay.
What are
Under
the
the
corneal
guarded
findings?
visual prognosis. Corneal finding like size is slightly reduced. But size is
Is the
10,
cornea
11.
clear, lusterful, or is there anything there which is suggestive of?
Ma'am, cornea was clear.
There was no band keratopathy?
No, ma'am.
And patient is giving this history of deviation of eye and all since how long?
Ma'am, since 2000, around when the patient was at 8 year of age, I think.
So many years back, isn't it?
Yes, yes, ma'am.
Unlikely that the patient doesn't have a band keratopathy. You are saying that you want to operate on this patient. You think the patient is going to get back any vision?
Very less chances, ma'am, under very guarded visual prognosis.
What is your less
I
chances?
will
1%, 10%, 50%? I'm giving you an MCQ, 1, 10 or 50%.
10% around, less
10%
than
chances you think patient will have vision. What was the intraocular
I
pressure in the right eye? 14. In the left eye, it was 10.
10 millimeter.
Yeah. So when you're having an intraocular pressure difference of 4 between the two eyes, what is happening in that eye with a retinal detachment behind? You can't see.
At
See,
the
even if
place,
there's a retinal detachment and you're not getting any glow, means there is a PVR over there.
yes, ma'am.
Correct?
Yes, ma'am.
So if there is a PVR behind and your intraocular pressure is 10 millimeters, what are you anticipating? The low pressures are because of what?
And retinal break may be there, or like the vitreous
You
fluid
forget
may
the
seep
posterior
into the brain.
segment. We are not retinal consultants. That Piyush will decide, okay? Anteriorly, what can you think of? What will bring down the intraocular pressure? What forms the aqueous humor?
Uh, Parts placata part of the ciliary body.
Ciliary body, correct?
Yes, ma'am.
So if your intraocular pressure is low, what is happening in the ciliary body?
Ma'am, ciliary body shut down maybe there.
So if
in this
there is
case.
already a impending shutdown, your operating is going to help the patient or it's going to cause a thysis bulba.
Ma'am, it will to the thyroid bulb.
So you should not touch the patient.
Okay, ma'am.
But that patient has come to you, means he wants something to be done. So
Yes,
max
ma'am.
what you can do is give him a cosmetic correction for the alignment, which is up and out, correct?
Yes, ma'am.
So you can do something to the muscles, but don't go anywhere inside the eye because that will cause a ciliary shutdown. And that also guarded prognosis because he's of that young age where he wants cosmetically things to look normal. But if you touch him, then he is going to get a chronic red eye, an irritable eye, and it might even go into phthisis. So he's going to blame you for all that things that happen later on. Despite everything in his eye being wrong, he's finally going to blame you for whatever has gone wrong. Okay. So you should stay away from all these things. And even if you decide to touch him, what kind of a consent will you take from this patient? Any special consent you will take?
Ma'am, video consent.
Yes.
Maybe so.
You will always take an audio visual consent in such cases because he is very young. He can sue you even after 20 years, saying that I was never explained and this happened to me. So even if you touch him, giving him all the pros and cons, you have to take an audio visual consent and retain that consent in your email drive till you exist or he exists, one of the two. So best is not to touch these patients and tell them that nothing can be done. Max cosmetical corrections. Okay.
Yes, ma'am.
Sir, if you want to ask something.
So if there was no RD, so how you would like to manage this case?
Just
And
forgo
As
all
the
other
cataract
parameters
surgery.
uh, uh, except the IOP, everything is fine except the RD. There is just coloboma, iridolentricular plus RC coloboma. So how would like to manage this case?
Just go for the cataract surgery, sir.
Hmm.
Like, and
What
putting
method?
IOL.
What method do you want to
Sir,
use?
for the safer side, I
SSGS
will
fake.
go for the, sir, for the safer
Keeping
side, I
this
will go,
cataract into consideration. It's a hard cataract, what ELC
mm,
fibrosis, everything is there. So what type of approach you would like to?
sir, I will go for the manual SICS
Okay.
first.
Would you like to put CTR?
Yes, sir. But after the like, make, first complete the capsular access because NPA capsular fibrosis are also present. So, uh, I can use also the iris hook retractor for the like iris retractor and iris hook and for the capsular tensioning to stable the bed also.
Okay. Would you like to do anything pupillary procedure for this case?
Pupilloplasty can be done
Why?
for the
Why?
uh,
Why do you
like
want to do pupilloplasty?
Sixers knot technique or the mechanical technique
No,
can
no.
be
Why?
done
Why do you want to do pupilloplasty?
to
Is
avoid
there any reason?
the uh,
Is it going to
photophobia.
benefit patient?
Yeah, for the cosmetically and for the cosmetically and
No, I'm
for the
not talking
photophobia.
cosmetic. I'm talking about
Photophobia.
visual acuity.
For
Vision.
photophobia to avoid photophobia.
Patient had this type of pupil since childhood, right?
Yes, sir.
Then why do you want to close that defect, which was there naturally?
Sir, now the patient have no complaint. Like if the I will do the cataract surgery, then the vision is occurred. So to avoid the photophobia, I will repair the iris also.
No, no, I think you didn't understand my question. I'm just asking you. Patient had this defect since childhood,
Yes, sir.
correct? Cataract
Yes,
had
sir.
developed recently, correct? So, like whether patient had this photophobia since childhood or
No, sir.
that's what. So, my question here is,
Mm,
do you really want to close the defect?
mm. No, sir.
And will it help patient?
First, I will explain to the patient, and when he agree for the another
Have you
procedure,
heard of
other procedure like iris repair, so we will go for the surgery also.
Arey beta, the capsule will opacify, no? So why you need to do all that? There will be no glare
Mm,
in that
not
quadrant.
necessary.
Again, there is a choroidal coloboma behind. So what are you doing? Correct?
Okay.
The
Sir,
less
ma'am, would you like to ask her about the other congenital anomalies or something which are normally asked in the MS exams? So, Dr. Deeplata, can you answer about the other congenital anomalies which are seen in the eye?
what is the difference between Peters anomaly and Riger's anomaly?
Mm.
Where do they happen? At least you know what happens in them.
Um, it lead to the glaucoma, and I just remember it's angle anomalies. Mhm. articular anomalies are there in
What are eye syndromes?
iridocorneal endothelial syndrome. And
So,
yeah,
are these two a part of the eye syndromes or
and
no?
um, Axenfeld, I think eye syndrome is there.
Ravi sir, what is your experience when you deal with the iris coloboma with cataracts?
See, that's what. See, basically, I look for phacodonesis. If there is a phacodonesis, my management will be entirely different. If there is no phacodonesis, I would like definitely try with phaco. So here, what extra I do is I put iris hooks superiorly where there is no coloboma, so that I'll get a better field visibility. One. Second thing is, once I finish my rexis, I would like to support the area of coloboma using a capsular hook, so that uh, the further ZD will not happen when I'm doing phaco. And third thing is like CTR, would like to use at the end of the nucleus management. And I don't want to close this defect, as ma'am also already said. So there'll be a fibrosis and it's not going to give any photophobia to the patient. And it's a natural defect which was there with patients since many years. So obviously it is not going to cause any problem. So iris hook for in the superior area and capsular hook in the coloboma area to support the capsule. And once the nucleus management is over, then CTR. This is what I follow.
They have weird refractions, weird IOL powers. The anterior chamber depth is very irregular. The less maneuverability you do within the eye, the better it is, I feel.
Yes, ma'am.
Finally, they have to see, no, that's all. And it's usually unilateral. So whatever you do, the patient is never happy because he's seeing so well with the other eye.
Sir, and what is your experience with the IOL? Like, do you customize the IOLs or what do you do? I mean,
Yes, ma'am. Sometimes what happens, that's what you see, coloboma involving macula, so obviously the prognosis will be poor. So coloboma where the macula is not involved, so obviously the vision potential is better. And sometimes these cases are associated with microcornea. So in that case, definitely I would like to customize the IOL. And second thing is, even if it is a microcornea or macrophthalmus, the 13 millimeter IOL, whatever you get. So once you put it in the bag, the size can come down to around 6 to 7 millimeters. Even if you have a 9 cornea, 8 cornea, the same IOL can be used because the haptic optic will get compressed and you will end up having almost around maybe a 9 millimeter IOL. The like haptic optic together I'm talking about. So, and one more thing, you can do a UBM to know the sulcus to sulcus. In case if sometimes what happens, the cornea, microcornea will be there, but the eyeball will be normal. So in such cases, you don't have to do anything. So if entire microophthalmus, then you may have to customize the eyeball. And last, you can trim the haptic also sometimes. You can just cut the haptic off and keep only the optic. That also can be.
okay. And ma'am, Nita ma'am, what is your experience
Experience regarding
regarding the coloboma with the cataract?
the intraocular lenses.
Yes, ma'am. I mean, how do you go about the surgery?
That's what I said. It's usually unilateral. So whatever you do for the patient is not happy.
Mhm.
So if it is a retinal coloboma, the least you do, the better, because someday or the other, the patient is going to go into an RD. That is the unsaid rule. But if you have a proper retina without a coloboma, then yes, give the best chance to the patient. And as sir said, most of the IOLs, they will try and fit themselves in the bag. The best thing is not to break the bag. Whatever you do, your IOL has to be within the bag only, then it will get compressed and it will stay over there. And yes, you can get customized IOLs. Most of these patients, they have a minus refractive error. So the uh, intraocular power is less than 20, 17, 16. So the thickness of the lens is not so much that it will come in the way of your putting in the bag. So most of the times, like, if you have those Rayner models, you can just cut the upper part of the haptic and it will settle in. Or you can take a 3-piece IOL where there are flexible loops, so they will settle in. But I have once or twice even got lenses made where the total diameter of the lens was 10 millimeters. It was made by Care Group for me. And the microcornea was too much. So as a result of which we had to get this custom IOL done from them, but it fitted. And but in this case, the IOL power was somewhere around 25. So it was a proper customized IOL with 10 total diameter. And again, as I said, the patient never gets 6x6 vision. So whatever you do, at the end of the day, 2 weeks later, the patient will come and say, "Iske jaisa nahi dikhta hai." So whatever you do, the patient is never happy. How many ever audiovisual consents you take, the patient is never happy.
Yes, that's true, ma'am.
Ravi sir, one question here. Like you said, the 13 millimeter lens will try and fit into 7 or 8 millimeter place as well. But with that,
Yes.
don't you think there could be a more chance of subluxation, or maybe the effective lens position will go too much backward, or since the inferior zonules are not there only, uh, have you experienced any subluxation after putting a normal lens in smaller eyes like 8 or 9 millimeter?
Not really, not really. Anyhow, we are going to put a CTR, no? So I don't think it's going to happen. So unless and until you disturb zonules during surgery, I don't think it's going to happen.
It is stretch, Sumit. It doesn't happen.
Okay. Ravi sir, in case, sorry, we are asking at the last minute. If you have any video with you available at present, would like to see. Otherwise, we'll just.
It's there in hospital. So my hard disk is there.
No problem, sir.
Ma'am, sir, would you like to ask more questions regarding the coloboma and the cataract?
I don't know. I feel I should give them a piece of advice that when they come with the case for a presentation in their exams, they should not only think about that particular patient. They have tubular vision. So when you ask them questions which are not related to the patient, they blank out. So go with an open mind. You can be asked anything in an exam. I mean, like sir said, if you don't have a retinal problem, what you will do? So then, you don't have to fumble at that situation. And refraction of the patient is ultimately the crux of what is going to happen. So even if you have a cataract, a dilated retinoscopy of the patient must be done, because the patient sometimes accepts -5, -6 because of lenticular sclerosis, but a retinoscopy is not so much. So it's a lenticular cataract. So go with an open mind and you will be asked anything. Sometimes we want to know whether you have read, so we will probably not ask you about the patient at all.
Dr. Deeplita, would you like to tell us about briefly about the embryology of the eye? How does the eye develop?
Eye is developed from the prosencephalon, a part of the forebrain, and protrusion arises from the prosencephalon, the optic stalk and the optic vesicle. Then invasion occur and form a optic cup. Outer layer of the optic cup form the retinal pigment epithelium, and the inner cup form the neurosensory retina, and the optic stalk form the optic nerve. Hmm.
How does the lens
And
develop?
the lens, the prosencephalon lined by the prosencephalon from the neuroectoderm, arise from the neuroectoderm. So neuroectoderm layer by the surface ectoderm. When the optic cup forms, the lens surface ectoderm invaginate into the optic cup and form the lens placoid, and further it form the lens. So the lens is formed by the surface ectoderm.
And the muscles of the iris, they come from which layer?
And the iris muscles arise from the neuroectoderm only.
Okay, good. So Dr. Piyush, and I think Shirish sir is also there. So would you like to have some comments, sir? Shirish sir?
It was a nice PG program, but I wanted to tell the students just try to catch up hints given by the examiners. They are giving so many hints to you. You need to have, the acumen of catching the hints. And second, you can't afford to confuse the basics. Nobody, expects hyper things directly from you. Yes, don't get confused in the basic like CTR, back fixation, all this. But that's all from it. Overall, it was a very good presentation. Just go, as Nita Madam said, go open-mindedly and be prepared with everything around also. Not be in tubular vision mode. Just go open-minded. That's.
Dr.
I think
Piyush?
that's I think they've already mentioned what Shanbag Madam, she teaches me still. So, we all have to not just keep an open mind, but both of you all need to relax. Dr. Deeplata, I'm sorry. The important thing is that you were listening to questions. That's very important. Preeti, I think, was a little nervous. She's a second-year resident. I'm so sure she'll do well in the future. You'll need to listen to questions. The question might be pertaining to to the case, might be something else, could be so many things. So first you have to listen to the question and then answer. I think this will all come with time, and what is important is that you'll have a platform and you'll are utilizing that. So I'm deeply grateful for that. I'm deeply grateful to Professor Vare, who does this day in and day out. And of course, to our expert panel examiners, Shanbag Madam, Ravi sir, both of you all, thank you so much for taking out the time. I would like, in fact, our Secretary Scientific Committee to say a special thanks to both of you.
Yes. Thank you, Neeta ma'am and Ravi sir. Thank you for agreeing to be part of this webinar just on a single message. Just to tell you, my first case presentation I had done in front of Neeta ma'am, and I was in the same situation or maybe worse than what Dr. Preeti and Deeplata were today. So, of course, she is a teacher at par excellence, and we always learn from her. Thank you, Neeta ma'am, for always being there. And Ravi sir, I specifically asked him for a video right away. I should have asked him much before. Sir is a prolific surgeon, and it is beauty to watch him operating. And again, he's someone who can teach you just by looking at your surgical videos. I have heard about him lot from all the fellows, and they all praise him like anything. Thank you, Ravi sir, for being there. It's a pleasure to have you on the MOS webinar. Thank you.
Thank you. Neeta ma'am, do you know Professor T.K. Ramesh? Have you heard
Yeah.
of him? Yeah, you just remind me of him today. So the approach to the case, no, so absolutely stunning. So that same thing you used to ask, like one by one, like if at all, if we used to tell him that I don't know the answer, then he used to start from the basic. Then ultimately he make us to answer. That's what the way. So you also had the same way to like teach the
So we
students.
have to make them comfortable, but then if they don't know their basics also, then there's nowhere for us to go also.
So
We
true.
try to go back to the basics, at least thinking that they know their basics, we can get them through. But sometimes, they fumble even in their basics. So that's what I tell them. If you have done 3 years of residency and you have actually worked very well within the wards and the OPDs, you're going to clear your exams without any doubts.
Yes,
Because
ma'am.
finally the examiner
Absolutely.
will go into the basics, and if you have worked properly, the basics are going to be clear.
That's right. That's right.
You'll make
So I'm
ophthalmologists out of
thankful to Dr. Renu ma'am and Dr. Rohit sir for mentoring their students as well. So with
Thank you.
permission of Thorat sir and Dr. Piyush, can we conclude this session?
Yes, ma'am.
Yes.
Thank you so much.
I want to thank everybody, especially the kids, for coming forwards and presenting. That's itself a very great gesture.
Absolutely, madam. Takes a lot of courage to both of them and all of the residents who've been presenting. And
They have to do it. It's a nice forum, so I think they should come forwards and do it.
yes, ma'am. Thank you so much. Thank you, Archana, ma'am.
Thank you. Thank you. Good night.
Thank you.